من اللغة الإنجليزية إلى اللغة العربية للترحيب بالأستاذة التي جاءتنا من جمهورية مصر العربية. مرحبا بك. نقدم الأستاذة القرشي، أستاذة جامعية بجامعة القاهرة كلية الطب، لتقديم عرض حول ارتفاع الضغط الدموي الرئوي في الأمراض الرئوية الخلالية.
يعني هو
فلتتفضل مشكورا.
اولا انا بشكر حضرتك جدا جدا على المقدمه الجميله، وطبعا بشكر الدكتوره هند وسعيده جدا لوجودي معاكم. انا فعلا جبت مسافه كبيره، بس كنت سعيده قوي قوي ان انا هشارك اخواتي في المغرب العربي الشقيق. الحقيقه هو انا هتكلم بالانجلش، يعني ام سو سوري بيكوز احنا طبعا معظم الطب عندنا بالانجلش، بس احنا وي يوجوالي توك ان عربي. لان احنا وي ريلي يعني افتر some surveys كده اللي احنا عملناها في مصر، لقينا انه الطلب العام انه هو دايما المحاضرات تكون انجلو Arab and respecting the mother language يعني المصريين. علشان كده I will talk in Anglo Arab if you want, and I will talk in English if you want, no problem. Ladies and gentlemen, يعني بشكركم جدا جدا على ان انتوا قاعدين لحد دلوقتي الحقيقه. وعارفه ان انتوا اكيد صدعتوا جامد يعني، لكن انا هبتدي كده in short. I will talk about the pulmonary hypertension, and I know actually I knew from my colleagues here that pulmonary hypertension may be related to the cardiology rather than the pulmonology here in Morocco. But I will give some highlights about the pulmonary hypertension that's associated with the interstitial lung diseases, because most of us usually see interstitial lung diseases in our clinic every day. So we will tackle how to approach these patients. الحقيقة الصورة دي this is my place, قصر العيني Hospital of Cairo University. Actually قصر العيني هو 14 hospitals together. We have the capacity of 5,600 beds. القصر العيني تم إنشاؤه 1827، وفي خلال 3 سنين إن شاء الله نحتفل بالعام ال200 لينا. We serve around 2 million people in the outpatient department and about 500,000 in the inpatient department, and we perform 2,800 operations per year. So when we talk about the interstitial lung diseases, actually we all know that interstitial lung disease, this is a big umbrella, and there is a lot of diseases that can be under the term of interstitial lung diseases. الحقيقة إن هي كلها تتشارك في إن هما they have the same outcome. يمكن إحنا early in the disease we can find that there is some differences actually in the etiology or in the clinical manifestations of the patients, and in the pathophysiological changes that we have, and in the radiological finding. لكن finally the outcome is the same. They are all having interstitial lung fibrosis and respiratory failure and hypoxia. When we talk about the etiology per se, we will find that we have some diseases that may be idiopathic, like the interstitial pulmonary fibrosis. Some are inhalational, like that with the hypersensitivity pneumonitis, and this is very important in Egypt because this is the first cause of the interstitial lung disease in Egypt. Actually في مصر احنا معروف عننا ان احنا الشعب كله يعني تقريبا بيربي حمام. That's why we have a high prevalence of hypersensitivity pneumonitis in Egypt, and we have immunological problems like those with rheumatoid arthritis, with Sjogren's syndrome, with scleroderma, and some cases of systemic lupus erythematosus. We may have iatrogenic interstitial lung diseases like those receiving amiodarone for arrhythmia, and those receiving methotrexate in cases of connective tissue diseases, and even infection. And we all saw the COVID and the post-COVID fibrosis that we have, and also the neoplastic transformation like those with lymphangitis carcinomatosa in cases of breast cancer and so on. What is the incidence of the pulmonary hypertension in different interstitial lung diseases? الحقيقه احنا هندي بعض الامثله كده على الانترستيشال lung diseases وهناخد varieties من كل مكان just to know that pulmonary hypertension interstitial lung disease this is not a disease per se, it's just a state that's associated with other problems. So I cannot deal with pulmonary hypertension associated with interstitial lung disease as a certain and one disease. When we are talking about the pulmonary Langerhans histiocytosis, the incidence is 62 up to 92 in some studies, and in some studies mentioned 100% of the patient with pulmonary Langerhans histiocytosis will develop pulmonary hypertension. When we talk about the combined pulmonary fibrosis and emphysema, up to 90% will have pulmonary hypertension. When we talk about hypersensitivity pneumonitis, almost 28% of the cases, and this study was performed in Egypt actually, 28.3% of the cases having pulmonary hypertension. When we talk about the interstitial lung disease associated with connective tissue disease with all its varieties, rheumatoid arthritis, Sjogren, systemic sclerosis, we found that it's around 28%. And when we talk about the lymphangioliomyomatosis, it's low, up to 7%. And in case of sarcoidosis, it may reach up to 28.3%. So we have a diversity in the frequency of the pulmonary hypertension in different interstitial lung diseases. طيب أنا لما بشوف الكلام ده أنا ليه بدور يعني ليه أبحث عن pulmonary hypertension in patient with interstitial lung disease? Actually because لو أنا ببص من منطلق pulmonary hypertension يعني from the pulmonary hypertension perspective, pulmonary hypertension associated with chronic lung disease accounts for the second most common cause for pulmonary hypertension all over the world. طبعا the presence of pulmonary hypertension with a patient with interstitial lung disease carry a very bad impact on the outcome والmortality بتبقى very high. And when we know that pulmonary hypertension, usually the group 1 or the idiopathic form that's treated by the specific vasodilator therapies have no or limited role in this group. And finally, and this is very important, and sometimes interstitial lung disease may obscure the primary cause of the pulmonary hypertension. الحقيقة هي هتبقى فرصة للمحاضرة السابقة إن إحنا نتكلم في النقطة دي. In case of interstitial lung diseases due to hypoxia, these patients may develop repeated showers of pulmonary emboli. And finally, we'll find that this patient having chronic thromboembolic pulmonary hypertension, this is not pulmonary hypertension secondary to the hypoxia of the interstitial lung disease. The second point is, in case of connective tissue disease, and this is very important because this is a prevalent disease. In connective tissue diseases, we have two items. We may have interstitial lung disease that causes hypoxia and hence pulmonary hypertension due to the pulmonary vasoconstriction, and we may have what's called the vasculopathy. Vasculopathy means permanent changes in the pulmonary artery and pulmonary arterioles itself because of the disease and not due to hypoxia. So I may have an element of group 1 or pulmonary arterial hypertension, or I may have pulmonary hypertension secondary to the hypoxia that's associated with the interstitial lung disease. So this is very important to differentiate. From the pulmonary hypertension perspective, the WHO and the guidelines, the European Society of Cardiology in collaboration with the European Respiratory Society that has been published in 2022, we have 5 main big classes of pulmonary hypertension. We have the group 1, which is idiopathic, heritable, or associated conditions like the HIV, congenital heart disease, connective tissue diseases, chronic liver diseases, and portal hypertension. The group 2, which is the most prevalent all over the world, is pulmonary hypertension secondary to the left heart disease. And group 3, which is the second most common form, is pulmonary hypertension associated with the chronic lung disease that should be destructive, chronic destructive lung diseases and or hypoxic conditions. And group 4, which is the pulmonary hypertension due to chronic thromboembolic pulmonary hypertension or even multiple obstructions, either due to clot formation like multiple showers of pulmonary emboli or other causes of obstructions like the angiomyosarcoma. And finally, the group 5. Group 5, which may be we have 2 mechanisms or more or unknown mechanism for the production of pulmonary hypertension, like cases of sarcoidosis. So when we allocate the diseases that we mentioned previously in this slide, we will find that the connective tissue disease associated interstitial lung disease may be of group 1
and we have vasculopathy, and may be related to group 3, which is secondary to the hypoxia. When we talk about the hypersensitivity pneumonitis or the idiopathic pulmonary fibrosis or the lymphangioliomyomatosis, this is purely due to the hypoxia. And when we talk about the sarcoidosis or the pulmonary Langerhans cell histiocytosis, we have many mechanisms for the development of pulmonary hypertension, so it is present in group 5. What is the difference between each group and the other? The difference mainly is the way of treatment, the treatment strategy. When we talk about group 1, we are talking about specific vasodilator treatment. When you talk about group 2 and 3, please treat the cause. Don't give specific vasodilator. When we talk about the chronic thromboembolic pulmonary hypertension, you should give the patient specific vasodilator and you should intervene with the patient. لازم أعمل حاجة، يعني يا إما أدخل أشيل الثرومبس جراحياً، يا إما أدخل بالقسطرة وأعمل توسيع, what's called the balloon pulmonary angioplasty. And group 5, this is an individualized approach. Each patient per se, كل واحد بحالته. ما ينفعش أخد العيانين على بعض. And there is no guidelines for the management of group 5 pulmonary hypertension. So, the pathogenesis, actually, because we have different etiologies, so this implies the presence of different mechanisms. Like, we have hypoxia, which is a key role in all group 3 pulmonary hypertension. We have destruction of the pulmonary vascular bed, so finally the surface area that was present for the exchange of the gases is narrowed, and so I have increase in the pulmonary vascular resistance. And then we have inflammation like those with the autoimmune diseases and the autoantibody. Okay, we have cigarette smoke toxicity like those with pulmonary Langerhans cell histiocytosis. And we have endothelial-derived imbalance between the vasoconstrictors and the vasodilators, which is present in cases of the group 1, what's called the vasculopathy. And finally, we have the presence of certain comorbidities like the chronic thromboembolic or an associated left ventricular dysfunction. So all of this results in what's called the ventilation perfusion mismatch. And this is the target. When we have a ventilation perfusion mismatch, this leads to pulmonary hypertension. So how to approach the case of pulmonary hypertension? This is very difficult. Why is it very difficult in the context of interstitial lung disease? Because all the symptoms that we have in interstitial lung disease is similar to the primary disease. يعني ببساطة, pulmonary hypertension causes dyspnea. Interstitial lung disease do this. So pulmonary hypertension causes dizziness, fatigue, decreased exercise tolerance, and increased oxygen demands, yet interstitial lung disease do so. So many physicians consider this as the natural history of the disease of the interstitial affection. And this is the natural progression of the disease. Yet when we have a syncope or arrhythmia, this may let the physician think that we have a vascular derangement, so he may think about pulmonary hypertension. Actually, the second problem that we don't have a validation for a screening tool for these patients. Yet we don't have validation. There is no validation in Europe and there is no validation in Egypt. I don't know يعني, your system here, but هل انتوا regularly بتعملوا echocardiography for patients with interstitial lung disease, ولا just when the patient is complaining only of something aberrant to the interstitial lung disease? Actually, this is a problem all over the world that we don't have a validated screening strategy for this patient. Yet, احنا recently يعني بعد ما عملنا وحدة البulmonary hypertension تقريبا احنا yearly we perform echocardiography with right side protocol for all patients with interstitial lung fibrosis or upon clinical deterioration of these patients. والحقيقة ان ده بيحتاج high index of suspicion for the physician. يعني إذا حضرتك ما فكرتش في البulmonary hypertension مش هيجي في بالك خالص ولا عمرك هتطلب ايكو. high index of suspicion is very important to be put in consideration that pulmonary hypertension is an important complication of patients with interstitial lung fibrosis, so I should ask for echocardiography every now and then. When we perform the clinical assessment, we may find, unfortunately, if the patient coming with right side heart failure, and this denotes that we have an advanced stage of pulmonary hypertension. This patient is a terminal case, actually. And when we perform the pulmonary function, we will find that there is an unexplained decrease in the DLCO, or unexplained DLCO relative to the FVC, or the vital capacity of the patient. And when we found that the exercise tolerance of the patient that we have decrease in the 6-minute walk distance, which is unexplained, or we have exercise desaturation. This is very important to think about pulmonary hypertension. And when we perform the laboratory test, and this is not usually asked unless we have the suspicion of pulmonary hypertension, we will ask for the NT-proBNP, which is a hormone that's secreted from the cardiomyocyte. This hormone is secreted from the cardiomyocyte in response to the stretch of the cardiomyocyte. So when I find that the BNP is high, this means that I have a ventricular strain, whether the left ventricle or the right ventricle. This is non-specific, but it's very good for prognosis. And finally, when we see the HRCT of the patient, we may find those manifestations suggestive of pulmonary hypertension, like that increase in the pulmonary artery diameter relative to the ascending aorta, as we see here, or increase in the main pulmonary artery more than 29 millimeter mercury, or enlargement of the right ventricle enlargement, and cardiomegaly with dilatation of the pulmonary vessels. الحقيقة دي حالات حقيقية من عندنا يعني. أنا بس حبيت أوري حضراتكم السي تي الثاني. This patient has huge cardiomegaly. Sometimes this patient will not complain unless late in the disease, and this is very important problem. So pulmonary hypertension should be put in consideration and should be put in the back mind علشان ما يجيلناش البيشنت بهذا المنظر يعني صعب. And it's very important to know that the accurate diagnosis of the ILD pattern is the way to reach a proper management strategy for the patient with pulmonary hypertension. These 4 patients, هما برضو من عندنا في الوحدة بتاعتنا, all of them having interstitial lung disease, all of them having pulmonary hypertension. It's rather difficult to think that I will deal with these patients, all of them, as a one problem. No, because the first one, this is fibrotic non-specific interstitial pneumonia associated with scleroderma, and this patient should be considered as group 1 and will receive specific vasodilator medication. The second one is the UIP-IPF pattern. This is idiopathic pulmonary fibrosis, and the lower one is fibrotic hypersensitivity pneumonitis. This is group 3. Just treat the cause, give oxygen, give antifibrotics, and so on. And the final is the sarcoidosis, and this is group 5. We should individualize the approach. When we think about the patient that he may have pulmonary hypertension, please ask for echocardiography. طيب أدور على إيه في الإيكوكارديوغرافي? Search for the tricuspid jet velocity. If the tricuspid jet velocity is below 2.8, this is low probability for pulmonary hypertension. If it is more than 3.4, this is high probability of pulmonary hypertension. In between, this is intermediate, unless the patient has indirect signs of pulmonary hypertension, so this will shift the intermediate to high. What is the indirect signs? Which means very simple, all manifestations of right ventricular strain and dilatation. We have dilatation of the right ventricle, we have shift of the septum toward the left ventricle, we have small size capacity of the left ventricle, we have dilatation of the pulmonary artery, we have dilatation of the inferior vena cava. All manifestations that help to assign the presence of right ventricular strain. And finally, the right heart cath. This is the gold standard to confirm the diagnosis of pulmonary hypertension and to differentiate between pre-capillary and post-capillary. So in such patient with interstitial lung disease, is it wise enough to perform something invasive like the right heart cath for all patients? For sure, no. We will see in the next slide when to perform. However, it's very important to know that the right heart catheterization can differentiate between the pre-capillary part and the post-capillary part. The post-capillary part means that I have a left heart disease. Pre-capillary part, I have a problem in the pulmonary artery itself, which is group 1, or I have interstitial affection, which is group 3. So, right heart cath should be performed when the results will likely influence the management. ما تعملش حاجة ملهاش سبب. يعني هتعمل علشان عايز تعمل حاجة اعمل. لو ملوش سبب انك تعمل ما تعملش. ببساطة. يعني if I will include this patient in a clinical trial, or I will plan this patient for lung transplantation, or I am intending to initiate a vasodilator therapy because I think, in my opinion, that this patient is not purely pulmonary hypertension secondary to interstitial lung disease, please do right heart catheterization, or otherwise don't perform, put in consideration that right heart catheterization, we the pulmonologist do it in our department. This is a very simple test, and it's very safe, and it can be performed on outpatient basis and bedside procedure. We are not in need for a cath lab. We are not in need usually for a cath lab. So to summarize, when we suspect pulmonary hypertension, search for the symptoms and the signs suggestive of that, and think about performing pulmonary function testing, the DLCO and spirometry, and search for the 6-minute walk distance if it is reduced or not with exertional desaturation. Then perform the high-resolution CT to correlate between the extent of the fibrosis that's present in the HRCT and the degree of the pulmonary hypertension, and performing exercise capacity if it is present by the cardiopulmonary exercise testing. If you have the suspicion, please perform echocardiography to support your decision, is it right or not. If we found that we have intermediate or high probability, please confirm by right heart catheterization. To summarize also in another way, if you found that the patient with interstitial lung disease have mild pulmonary function abnormality, mild parenchymal affection in the high resolution CT with high pulmonary hypertension, this should be considered as group 1. If the patient having moderate to severe functional abnormality and radiological finding with severe pulmonary hypertension, individualize the approach. While if the patient with severe affection of the pulmonary function and severe high-resolution CT changes and mild to moderate pulmonary hypertension, this is secondary to the hypoxia and interstitial lung disease, please return to the etiology and treat the etiology. What are the criteria of severe pulmonary hypertension in the right heart cath? 3 parameters that we use in the right heart cath. We measure usually the mean pulmonary artery pressure. If it is more than 35, this indicates severity. Or the cardiac index, which is less than 2.5. Cardiac index means that I have a problem in the perfusion of the whole body. And finally, the PVR, if it is more than 5 within it. To treat or not to treat, أنا الحقيقة لأنه عشان الوقت هيخلص فأنا I will pass through the studies يعني سريعا. الحقيقة الستاديز ما كانتش مفيدة قوي لأنها كانت معظمها كلها مجموعات صغيرة ما عدا الاستادي دي. The only study الحقيقة اللي كانت لها منطق اللي هي inhaled treprostinil. Inhaled, this is the only inhaled form that they work on. All of the drugs that they worked on before was oral drugs, systemic affection. While in case of the treprostinil, this is inhaled treprostinil and was FDA approved because it causes improvement of the exercise capacity and reduces the internal pro-BNP, and there was decrease in the pulmonary vascular resistance. That's why the guidelines بوضوح شديد قالت ان احنا we may consider inhaled treprostinil to in patients with pulmonary hypertension associated with ILD and don't give other oral drugs. والحقيقة why we should not give oral drugs, because it's all about the VQ mismatch. When you give an oral or systemic vasodilator, you will aggravate the ventilation perfusion mismatch that we have in this patient. So my take-home message, in case of a diagnosed case of interstitial lung disease associated with pulmonary hypertension, if it is considered as group 1, please go for specific vasodilator. If it is considered as group 3 with mild pulmonary hypertension, please treat the cause only. If it is considered as group 3 with severe pulmonary hypertension, please individualize the approach for each patient and watchful monitoring for initiation of specific vasodilator in cases of pulmonary hypertension to guard against the aggravation of the hypoxia and increase the ventilation perfusion mismatch. And thank you very much.
شكراً أستاذة قراشي على هذه المحاضرة القيمة، والحضور الكريم إذا كان هناك أسئلة بأي لغة، عربية فرنسية إنجليزية.
شكراً جزيلاً for your nice presentation.
Thank you.
Thank you very much. I have one question for you. How do the results of the recent clinical trial, particularly those of inhaled nitric oxide and tryptostina, influence treatment strategy for pulmonary hypertension in the context of pulmonary fibrosis?
هو الحقيقة إنه النيتريك أوكسيد is a very nice option, but the nitric oxide is a very complicated setting. Just to give the patient inhaled nitric oxide, which is used in the reversibility test during the right heart catheterization, you will have a big tank like this, and you will have a flow meter, and you will have a setting which is really complicated. So it's rather difficult to give a patient this setting at home to treat with inhaled nitric oxide. While inhaled treprostinil is given by a small device like the nebulizer, and the patient takes from 6 to 9 times per day, and it's really, the half-life is very short, but it gives good response actually. So the patient may have a small device and taking about 9 sessions per day and will give a good response. This is the inhaled treprostinil. حاضر. تمام. البروفيسور الحقيقة سأل سؤال، احنا عندنا 2 أدوية، الاثنين بيعملوا potent vasodilation، والاثنين بيتاخدوا عن طريق الاستنشاق. واحد اسمه نيتريك اوكسيد and واحد اسمه تريبروستينيل. النيتريك اوكسيد ده يوجد في اسطوانه، والاسطوانه لازم يكون ليها مخرج، وسيتنج صعب جدا، يعني حاجه صعبه جدا تواجدها في اي منزل، وغالي الى اقصى درجه. عشان السيتنج ده الاسطوانه دي بتكلفنا احنا في مصر تقريبا في حدود 150,000 جنيه، تقريبا بتقعد معانا حوالي 3 شهور. فهي غاليه جدا، صعب جدا ان انا المريض اديله اسطوانه كبيره وحاجات علشان يقعد بيها، لان هو هيبقى مرتبط تماما بوجوده جنب الاسطوانه، يبقى اذا هو لا يوجد quality of life of the patient is very bad. لكن الانهيلد تريبروستينيل يؤخذ عن طريق الاستنشاق بجهاز يشبه النيبولايزر، جهاز صغير قد كده. علشان كده it's very simple for the patient to take a session، ماشي، البيشنت يقدر يروح ويجي ويتعامل ويعمل كل اللي هو عايزه and will take another session. بناخد قد ايه؟ بناخد 9 مرات في اليوم عن طريق هذا الجهاز الصغير، ويسمح للمريض انه يتحرك، يسمح للمريض انه يخرج او يروح او يجي، وبالتالي التعامل مع الانهيل تريبروستينيل is very simple rather than ان انا ادي النيتريك اوكسيد.
شكرا جزيلا أستاذة ريم القراشي، وحقيقة ختامه مسك معك. It was a very interesting presentation and very attractive. I would ask you about when we have low risk of hypertension in the echography, is there any frequency to respect to repeat echography, or we can just assess patients clinically?
Okay. يعني up till now, honestly, there is no validated screening system for patients with idiopathic for interstitial lung fibrosis. However, in my center, we usually perform echocardiography yearly for all these patients and upon clinical deterioration. يعني بوضوح كده احنا لا يوجد validated system نعمل ايكو كل قد ايه للمرضى دول. علشان كده احنا in our center احنا بنعمل كل سنة للمريض regularly، يعني whether the patient is complaining or not complaining، بنعمل سنويا echocardiography with right side protocol، أو لو البيشنت حصل له clinical deterioration which is unexplained، يعني the patient may have مثلا acute bronchitis, pneumonia and something، يعني في سبب واضح. When we don't have a cause, just please perform echocardiography for this patient.
Thank you, Professor, for your nice talk. I am a radiologist, and I have a question about imaging. In my department, in the assessment of chronic pulmonary hypertension, we deal with dial energy CT scanning.
Dual, yeah.
Which gives 2 informations, morphologic information,
yes,
and perfusion information.
Yes.
And this completely replaced VIQ scanning.
Yes.
What do you think about that?
هقول لحضرتك الحقيقة. Actually, the problem of the ventilation perfusion scan right now that is not available in every place. Even in Egypt, we have a ventilation perfusion scan just in Cairo only, and we don't have in other centers in Egypt. Ventilation perfusion scan is a little bit difficult and expensive. However, the dual energy CT, up till now, we don't have also validation if we can use it instead of the VQ scan or not. Up till now, in the guidelines, the gold standard for diagnosis of multiple or chronic thromboembolic pulmonary hypertension is the presence of multiple bilateral mismatched defects in the ventilation perfusion scan. الdual CT هو الرول بتاعه لسه بيظهر، لكن up till now we don't have validation. الحقيقة إحنا في مصر we started this study علشان to show whether the dual CT can replace the VQ scan or not, just to solve our problem that we don't have VQ scan in every place. Yeah.
Just for information, there is recommendations, European recommendations about the use of the dial energy, which was published in 1991.
Yeah.
But this is maybe available only for Europe.
For chronic thromboembolic pulmonary hypertension. But it was not taken in consideration actually in the guidelines here. That's why we are trying to stick to the guidelines until we have a robust data about this. Okay. Okay, thank you.
شكراً على مشاركة الخبرات المصرية. سؤال أخير قبل أن ننتهي. القسطرة تقومون بها أنتم أطباء الصدر ولا ترسلون المريض إلى أنتم؟
هو في مصر البلمونري هايبرتنشن احنا this is a multidisciplinary approach actually. لازم يكون في pulmonologist, cardiologist, rheumatologist, radiologist، ولازم يكون معانا كارديوثوراسيك سيرجن يعني يكون عنده خبره فيها. بس الحقيقه انه في مصر البلمونولوجيست هم اللي are performing the right heart catheterization. However, when we perform the intervention for the chronic thromboembolic يعني البالون pulmonary angioplasty cardiologist بيعمله، لكن انا بشخص وهو بقى العلاج عنده هو.
شكرا جزيلا. شكرا.
Thank you very much, Professor Rim Korachi, for this refreshing overview on pulmonary hypertension. Je pense que c'est la fin de... On vous remercie pour votre patience et pour avoir posé... C'était une très belle session anglo-saxonne, en fait. Ça nous encourage à le faire plus souvent, je pense, pendant nos congrès. Merci à toi, Hind, d'avoir pris l'initiative de le faire. Finalement, il y a pas mal de personnes qui parlent très bien anglais. Je pense que c'est la dernière session. Il y a une pause café après ou... Il y a une dernière pause café, je pense. Et on donne la parole au professeur Serhan pour clôturer.
Bismillahirrahmanirrahim. Je vous remercie. هذا بالعربية، بالانجلي، بالفرنسي. العربية. تنشكر الحضور الكريم، كنشكر السادة الأساتذة اللي تفضلوا معنا وشاركونا في هذا المؤتمر المتواضع. تنشكر كل الزملاء اللي جاوا من البعيد ولا اللي حاضرين معنا في أكادير وفي النواحي. تنشكر كل الزملاء اللي جاوا من جميع بقاع العالم، لي 4 كوان دو موند. كنشكر الأستاذة ريم خاصة على المحاضرة القيمة ديالها اللي متعتنا. كيف قالت أختي وصديقتي الدكتورة حفصة، ختامه مسك. كنشكرك بزاف على المحاضرة القيمة ديالك. كنشكر اللجنة التنظيمية اللي قامت بمجهود جبار، كنشكرهم مع العدد القليل ديالنا حنايا كاملين. قامت بواحد العمل رائع. كنشكرهم كل واحد بالاسم ديالو. On aura l'occasion de les remercier tout à l'heure إن شاء الله في le dîner ou la soirée de gala إن شاء الله. Et je vous donne rendez-vous tout à l'heure إن شاء الله même endroit في نفس المكان. غادي يكون الحفل الاختتامي إن شاء الله في نفس المكان. ساعة غنقولها لكم إن شاء الله على الجروب واتساب. كلكم إن شاء الله غتكونوا معنا حاضرين، وتنشكركم وإلى الحلقة القادمة.